The debate is one trabeculectomy is done. The next, should we do needling or we should do retrab or AGV? So Ankur will talk about in favor of needling. Ankur, please.
Thank you, Dr. Rajul, Dr. Shefali, and Ajanta for having us here. And such a nice August gathering. I'll be talking in favor of needling in cases of trab failure.
Anyone in the panel, what is your choice of the minimal invasive glaucoma surgery? Sneha?
Yes, it actually, if I have a patient, I've tried MIGS, that's the eye stent and the hydrus, only in stable patients where the IOP is under control and they have some amount of cataract, and we are planning a phaco. I've done standalone MIGS as well, that's the eye stent. So if I'm looking at a pressure drop of about, I want the patient to be almost at least 2 drops or less, I would go for the eye stent in whatever little experience I have. But if I want more IOP drop, whatever little evidence is there, I would favor towards a hydrus. As of
Okay.
now,
Dr. Rita?
Yeah, I wonder whether, eye stent is even affordable to the Indian patient. One.
That is
Second, okay,
let us
second is that Ike Ahmed himself proposes that we should, identify the collector vessels in the periphery of which you can put in the eye stent so that there will be a good outflow from that eye stent. So do we have even the knowledge? So we are just like making a guess that I put in an eye stent here and it's going to work. So I for on my own, I have no belief in the procedure at all. The other thing is, I have another question in mind, that when we are destroying the we're doing a goniotomy, we're doing a trabeculotomy, whatever, we're doing a bang. How long will it be before fibrosis actually comes and closes the whole thing, and the Schlemm's canal is just not open to the aqueous? So, I'm waiting for long-term studies to come, which will actually prove to us that yes, these are alternatives that you can resort to as a routine. That's,
But
my point of view.
so no, no, English. Yeah. So the stent, you said that basically you don't know where to put in. That is why Ike says that collateral channels. But the studies do, when the compare studies showed very clearly that hydrus was much better than the eye stent. They said so. I totally agree that I don't think conjunctival mix is the should be considered as part of mix. And I think, but if you have to choose, because since you have option of almost of the minimal invasive glaucoma surgery, which one you will choose? As a
So
as along
this
with
is
the
my
let
philosophy. Okay.
Arvind, let me just finish question. One,
Okay.
so then you can answer all together. One along with the phaco and one is a standalone. The second, if the suprachoroid, the bypass was banned, matlab because of that endothelial cell loss, but which part you think has a maximum potential to work as a minimally invasive glaucoma surgery in the future, out of the uh, trabecular meshwork or US scleral?
I think where we currently stand, and I agree with the previous speaker, if you put a stent in, essentially what you're doing is you're replacing medicine. I think stents are not really good at reducing intraocular pressure as what you would want in a glaucoma practice. I think stents seem to work more in a comprehensive practice where patients show up with stable glaucoma and on meds and have a cataract. You're taking the cataract out, so if they have the money, they can put a stent in India to try and get them off medications. But if you truly want to drop the intraocular pressure, it seems that one of the trabecular meshwork destructive procedures seems to work a whole lot better, especially if you can viscodilate the canal at the same time. There seems to be an increasing role now for viscodilation, and actually that's coming out. There's some more studies looking at that. So my experience in the cyclodialysis space is pretty limited, supraciliary space. I was on the CyPass study panel, and we had a good mix of patients where it worked, but it's definitely a little bit more invasive because you're putting it in the ciliary body, and you think if you get it wrong, sometimes patients have a lot of inflammation. It's in the uveal tissue, and I'm not truly comfortable going there as yet. So in my book, in my practice, if you show up with a pressure that's super high, now whether I combine it with phaco or not is obviously determined by the age of the patient, the presence of a cataract. I think anybody over the age of 55, if they're willing to accept presbyopia, unless they're going to put a presbyopic lens, then I would consider cataract surgery. But you have a lot of patients out there who are very, very happy with their near vision and they read without glasses. And you actually anger some of these patients by taking the cataract out at that point, because now they say they can't see for up close. So I think you have to take that in mind. But I have a lot of younger patients with secondary open angle glaucomas. I have a couple of steroid-induced glaucomas, and I do offer. I do a lot of omni-GATs, and I do a lot of omni viscodilation as a standalone procedure, and it seems to work a whole lot better. The iStent just got recently approved by FDA for a standalone in the US about 2 to 3 years ago. I must tell you that my experience with that has been pretty dismal, actually. I think I've not had very good experience, especially in patients who they consider for refractory glaucoma. That's the indication. That means they've used everything at source. I think the surgery center makes a lot of money. The company certainly makes more money than the surgeon does, actually. So that's my take on that.
Okay. So Arvind, we'll start the talk, and at the end again we will have some more
Sure,
discussion. Yeah,
sure.
Ankur.
So I'll be talking about when the trab fails, we should needle the trabs. So when the trab failed, we all should know the art and the timing of needling. So this is a bleb which is post mitomycin C. We can see that this is relatively flat. There are angry looking vessels and there are some deeper vessels too. Another a bleb where we can see it is again flat, vascular, angry looking vessels, and they are superficial as well as deep vessels, and this one is without mitomycin C. So both trabs can fail, both blabs can get flattened, and they can eventually need some issues. So the problem usually is subconjunctival and the episcleral fibrosis. When to intervene when the IOP rises, even with the patent ostium on the gonioscopy, loss of bleb height, increasing vascularity, or encapsulated rings, which we all call as Tenon's cyst. The window of opportunity is to intervene early within weeks to months that give the best results. But in case of Tenon's cyst, we can even do needling later on. Now, this is a small video of needling. So I apply 0.04 milligrams per ml of mitomycin C for 2 minutes. Then I inject a little bit of saline to see that the conjunctiva cleanly comes over it. There's no strong adhesion which can create a buttonhole. I try go in. It is very tight to go from this side. So I change with a 26 gauge needle and do a kind of needling, remove all the tissue. So this is a little fast forward. So it may look little jerky, but this is what we do. We kind of dissect all the subconjunctival tissue and we watch for the free flow of aqueous from the bleb site into the anterior chamber. That is the end of needling. So after needling, I always advise a globe massage, which is a steady pressure at the inferior sclera for about 10 to 15 seconds, intermittent, and this is taught to the patient. They can do it on their own, along with the mitomycin C drops of 0.02% twice daily to be used for about a month. So now we look at the literature, what it says. This is the Nottingham cohort, which talks about a prospective study of 81 consecutive patients where a 5 fluorouracil augmented needling was done after a mean follow-up of 3.4 years. So the survival data shows that if the target IOP was taken as less than 21 or a 20% reduction of IOP after the needling, the 6-month survival was 64%, 12-month survival was 54, 24 months, that is 2 years, is 45%, 3 years is 31%, and after 4 years, it is 13%. So approximately 13 to 30% of eyes was saved over a period of 3 to 4 years for a repeat surgery. The predictive factors here was that the post-op IOP has to be less than 10 millimeters of mercury and should be needled within 3 months of original trabeculectomy. This was another study from Wilmer Eye Institute where they did add a continuous infusion. So this was a cohort of 106 eyes where needling was done with an infusion into the antechamber. The average time between the surgery and the needling was 4.3 years. And they advised, they found out 1 year survival qualified success of about 70% and 5-year qualified success of 52%. So this was pretty highly effective, avoiding trab surgeries or a resurgery in these patients by a factor of 50%. So here, probably the added on infusion washed away all the fibrin or the blood which could deposit underneath the conjunctiva when we do a needling. This was a study from India. This is the Hyderabad cohort where a mitomycin C and a slit lamp rescue for a failing trab was done. This was again a prospective interventional study mitomycin C 0.04% was injected before the needle revision, which was performed on a slit lamp. And the median interval between the trabeculectomy and the needle revision was 113 days, which is 3 to 4 months, and a median follow-up of 20 months. So they talked about an overall success rate of 84%, that is 71% without any anti-glaucoma medications, and additional 12 to 13% with anti-glaucoma medications. So they also said that the needling was pretty effective. This was another study from India. This is another prospective international study for subconjunctival bleb needling with 0.02 milligrams per ml of mitomycin C inside the OT. The duration post-Trab was 6 weeks to 2 years, and they achieved a success rate in approximately 40%, which was a complete success. Another 53%, they achieved a qualified success, that is with the anti-glaucoma medications, and failure was less than 10%. There were little complications, but most of them went on pretty well without any intervention. So this also provided a predictable low-risk filtration rescue in case of failing blebs. So in failing Trebs, failing blebs, needling is a viable option as it is effective, safe, cost-effective. There is an early rehabilitation. It postpones or averts a resurgical rate, and that's what we all do. What we all do is just postpone the blindness beyond the life of the patient. That's what we are doing in glaucoma. This is what I want to say. Thank you for your kind attention.
Thanks, Ankur.